Hello, I am Jolie Long with the National Board for Certified Counselors. On behalf of the Medicare Mental Health Workforce Coalition, we would like to welcome you to our webinar today. Next, before we begin, I would like to share some meeting details. Closed captions are now enabled and attendees can turn these on and off as desired. Interpreters can join the meeting via the phone number, ID, and passcode provided on this slide. A link to this PowerPoint presentation will be posted in the chat, so you can access the links on this slide. To receive continuing education, you must complete the session evaluation, including an attendance attestation. The link to the evaluation will be posted in the chat at the conclusion of the webinar. We will also send you an email with the link to the evaluation following the webinar. The continuing education survey link will let you complete the evaluation for one or both webinar sessions if you attended yesterday. If you need to edit your response after submission, you can also click the same link. We will only be providing continuing education credit for live attendance. This webinar will be recorded and made available on the NBCC website and other coalition member websites for viewing purposes only. Due to the large number of attendees, the participants will remain in listen-only mode throughout the meeting. The presenters will be taking questions at the end of the session, so please feel free to type your questions into the Q&A box at any time. Next. This is the 9th Medicare webinar that the Medicare Mental Health Workforce Coalition has produced. Please find information for videos of the previous presentations on the next 2 slides. The slides and video of yesterday's webinar will be posted on the website soon. Next. The Medicare Mental Health Workforce Coalition consists of organizations that collectively represent providers, clients, patients, and other stakeholders. Our overall mission is to increase access to client choice for mental health provider care. Together, we achieve this goal with the passage of the Mental Health Access Improvement Act. The coalition is now working to ensure successful integration of counselors and marriage and family therapists into the Medicare program. The coalition members are listed on this slide. Next. Today's webinar is the second in collaboration with the E4 Center for Excellence for Behavioral Health Disparities in Aging. Today, we are joined once again by 2 phenomenal and highly qualified professionals who will share information and strategies to help you address the clinical needs of older adults with mental health conditions. Today's webinar is titled "The Process of Working with Older Adults in Psychotherapy." I would now like to introduce our speakers. Their full bios are on the slides for your convenience. Erin Emery Tabricio is a professor of psychiatry, behavioral sciences, and geriatric medicine, and director of geropsychology at Rush University Medical Center. She is also co-director of the Rush Center of Excellence in Aging, co-director of Catch On, the HRSA-funded geriatric workforce enhancement program based at Rush University Medical Center, and co-director of the E4 Center of Excellence for Behavioral Health Disparities in Aging. Next. Matthew Fullen is an associate professor at Virginia Tech, where he teaches in the counselor education program. His research, teaching, and advocacy focus on the mental health needs of older adults with an emphasis on addressing gaps in Medicare mental health policy and developing programs to enhance resilience and wellness and prevent suicide among older adults. Dr. Fullen is the counseling profession's most active scholar on aging and mental health, with over 40 peer-reviewed publications and over 95 peer-reviewed conference presentations and keynotes. I would now like to invite Dr. Emery Tabricio and Dr. Fullen to begin their presentation.
Thank you so much, Jolie. Excited to be here with you all today, and wanted to just kick off our conversation today with just a comment about the E4 Center. We are focused on 3 key areas of depression, suicide, substance use disorders, and serious mental illness, and where they overlap to create or exacerbate physical health disorders. And for some, this is layered on top of low socioeconomic status and minority status that creates the most vulnerable population of older adults. And as we do this work to address the needs of this population, we have difficulty with slides. There we go. To address these needs, the E4 Center is focused on building knowledge and skills and attitudes in the mental health workforce, which we define very broadly, and now inclusive of all of you, working with health systems and the aging network to build partnerships to prevent older adults from falling through the cracks. And just a quick plug for some of our toolkits that you might find very helpful as new Medicare providers in building your business with older adults. We also provide training and technical assistance on evidence-based programs for older adult mental health and substance use. You'll hear about a couple of those today. And although we don't train older adults and families directly with E4, we do provide resources to equip you to share. So with that work, whoops, sorry, a little too quickly. The only disclosures that I have for today is that I am funded by the federal government through HRSA and SAMHSA for the work that is being presented today. So today we get to identify and challenge systemic and personal stereotypes and promote positive attitudes toward aging. We will talk through some of the normal elements of aging as they impact the therapy process and implement strategies for working with older adults to facilitate positive outcomes. Much like yesterday, for those of you who joined us, who are joining us again for the second day, we got a lot of information packed in today. So Matt and I are going to move through pretty quickly. Before we do that, though, I'm going to hand over to Matt to make a few comments about counselors and MFTs in particular.
It's so great to be with all of you again, and thank you, Erin, for allowing me the opportunity to co-present today. We had a lot of fun yesterday. We hope to do the same today. Just to sort of kick us off, I do want to note that according to the Population Reference Bureau, the U.S. population is older today than it has ever been. There are currently 58 million people over the age of 65 in the United States. This number will increase by nearly 50% over the next 25 years. By 2050, almost 1 in 4 Americans will be an older adult, including many of us attending this webinar. Moreover, the older population in the U.S. is increasingly racially and ethnically diverse, more well-educated, and working longer. Aging, as we know it in the United States, continues to evolve. Fortunately, licensed counselors and therapists are ready to evolve with it. You have skills in empowering clients, promoting holistic wellness, supporting couples, families, and other systems, and advocating for clients at the margins. And all of these competencies will be needed as our country grapples with what it means to age well. We know that mental health is critically important, and this is no less for people over the age of 65. But until recently, outdated Medicare policy, which hadn't been revised since 1989, was a major barrier that impeded licensed counselors and therapists from contributing to this cause. Now that Medicare law has been modernized with licensed counselors and therapists eligible to fully participate, the time is ripe to leverage our collective expertise to help older Americans experience mentally healthy aging. And that begins with trainings like today, but it also includes increasing the volume of aging-focused scholarship in the counseling and marriage and family therapy professions, revising accreditation standards to ensure age-focused education that is infused into our training curricula, and collaborating with other professionals, for example, those in the Aging Services Network, to ensure our approaches to mental health care are as culturally and developmentally competent as possible. Hand things back over to you, Erin.
Thank you so much, Matt. So as we get started today, I typically do an interactive exercise to start off this conversation. Because there are currently more than 1,200 of you in the room, managing the chat would be a little complicated. So I'm going to invite you to play along with this exercise, and I'll show you a little bit about how people tend to respond. So your first action here is when you look at this word, I want you to think in your mind about what images come to mind when you see this word. What images when you see this word? Typically, when I request that people respond in the chat, the responses I get are things like frail, dependent, old, gray, wrinkly, wheelchair, nursing home, grandma, grandpa, senior, wise. And as you see in a word cloud, right, those are, that's the larger the text, the more frequent those responses. So now I want you to take a look at the screen. And when you see these words, what images come to mind? Just think about that for yourself. What images when you see these words? And typically in the chat, the kinds of words that would come up would be things like retired, wise, relaxed, travel, grandma, grandpa, retirement, social security, pension, aging, gray hair. You'll notice that these are different words for these two different entities. So when we compare them, we look at the words that the images that the word elderly evokes on the left and images that the words older adult evokes on the right, we see some pretty big differences. And this is what gets communicated when we use these words, right? So when we talk about people over the age of 65 as elderly, research demonstrates in English in the US that we pigeonhole all older people into one image, which is not even close to representing people over 65. And it serves to reinforce those negative stereotypes of aging that harm every one of us. In contrast, when people use the words older adults, you see the broader ideas that reflect the broader experience of people over 65. Now, certainly you're also seeing some overlap, right? But the idea of older adults tends to include more positive images, and research demonstrates this matters to older adults' self-concept, and influences how we all think about aging. Because how we think about aging starts when we're very little. And so I do want to point out that there is a difference between the word elder, which often gets used in Native American and some other cultures, which is very much imbued with respect. But there is a distinction between elder and elderly. So my ask of you is that you follow the research and stop using the word elderly, and instead exclusively refer to people over the age of 65 as older adults. There have been questions about senior, and some people are okay with that. But generally speaking, the research is clear that older adults is preferred as we think about this. And it matters as we think about not just the words that we use, but the tone that we use. We've all heard elder speak. Sounds just like how we talk to dogs and children, right? That sing-song voice, those exaggerated words, simplifying sentences and speaking slowly, using small words, terms like honey or dear, and that so many statements sound like questions, right? We've all heard this. And it turns out that it is incredibly problematic. So when I was initially at Rush, I came in as a rehab psychologist, and my office was right around the corner from the physical therapy office. And as I sat there one day with my door open, I heard one of the physical therapists say, "Okay, honey, it's time to get up now. You can do it." And my eyes just bugged out and the skin stood up on the back of my neck. And I thought, oh, dear God, who am I going to have to go talk to about this? And I heard the response of, "Don't you talk to me like a dog." I thought, okay, good. So much better for that older adult to address that inappropriate behavior than a colleague as needed. But what's critical in that space is that older adults will feel like, and any of us would feel like, we were being treated like a dog if we were spoken to in that way. I was sick last week, and all of my colleagues were so kind to me when they heard me sort of croaking out my voice. And they said, oh, I'm so sorry. Are you okay? Can we get you anything? And in that moment, I felt cared for. But if that was how I was spoken to every single day, "Oh, Erin, how are you today? Are you okay, sweetie?" Oh my goodness. I would be so irritated. And it turns out that this is problematic in so many spaces, but it comes from a good place, right? So when we think about the kinds of language that we use, if we think about a care continuum and the amount of control we need to have over somebody's behavior, I am grateful to Mary Lou Chilfie for this slide from Sean Gordon's 2021 work that shows us that when we care a lot, but don't worry about how much control we have over somebody's behavior, our language tends to be very nurturing, right? And in contrast, when we don't really care that much about somebody, but we have a lot of control, you need to do this right now. It will be very directive language. And then if we don't actually care that much and we don't actually need to impact anybody's behavior, like a stranger in the grocery store, it's pretty superficial, not a whole lot of tone. The challenge comes when we care a lot and we have a great need to control someone else's behavior. So for example, a medical assistant in a nursing home who is trying to get somebody's care needs met, and they care a lot, but they also really need that person to get through the care. That is when elder speak is most likely. And so we need to think about that even as we talk to our parents or grandparents, and we just want them to get the thing done. And we're going to be most likely to engage in elder speak in that situation. So we really need to check ourselves in thinking about the kind of language that we use, because when we engage in elder speak, it actually doesn't help anything. It doesn't help comprehension. It also doesn't help kids' comprehension, by the way. And when people are spoken to in this manner, it threatens self-concept. If I was spoken to in that way every day, oh my goodness, I would begin to feel that I was not worthy of respectful tone. And for folks who don't have that ability to say, don't you talk to me like a dog, that increases aggression in people with dementia. So people who don't have the language to speak up and say, this is not okay with me, are much more likely to get physically aggressive. And this has been documented over and over in nursing homes. And so it turns out that when we train nursing home staff to change their tone to a respectful tone, removing that elder speak, decrease resistive behaviors in half. And if you think about engaging older adults in your clinical practice and you are using that respectful tone, you are going to be much more successful in engaging that older adult. Now, I've given this talk to lots of different kinds of professionals, and I've had the question asked so many times, well, how do I check myself? How do I make sure that I'm using a respectful tone? Well, one question I would ask you is, how would you talk to one of these guys if one of these guys was your client? Would you call former President Obama honey, sweetie, dear? I'm going to guess not. So you can check in with yourself. So we start this conversation about process of working with psychotherapy because what drives our skills and our behaviors clinically is entirely about attitudes. Our attitudes will drive our tone, our attitudes will drive our word choices, our attitudes will drive how we engage older adults in therapy. And at this point, I'm going to hand over to Matt to talk a little bit more about these attitudes and specifically about ageism.
Thanks, Erin. Yeah, we are all exposed to a variety of viewpoints about aging, whether that's through personal relationships, professional experiences, and yet much of that exposure is embedded within systems that have a high degree of ageism baked into it. One study that was performed looked at American views on aging and found that in the United States, aging assumptions, aging stereotypes had grown steadily more negative since 1880. And we're bombarded by these messages about aging, the vast majority of which are filled with negative age bias. Look no further than anti-aging cosmetics, anti-aging clinics, or your local grocery store greeting card aisle, and you'll see these messages about aging that we pick up on from a young age. And speaking of young age, if you tune into a children's television show or movies really geared toward people of all ages, you'll see some of those same negative stereotypes about aging. And don't get us started on social media, where there's oftentimes depictions of aging that are particularly harmful. In so many of these contexts, there's myths about older adults that are reinforced through this sort of discourse, in spite of these being myths. They're largely false, and these falsehoods really undermine the levels of diversity and heterogeneity that truly do exist within older adulthood. Some of these myths might look like this notion that older adults are pretty much all alike, all the same, that most are lonely or isolated, sick, frail, or dependent. Or they might be the stereotype that older people are depressed or cognitively impaired, or that older people are rigid and inflexible. And all of these are grounded in mythology. They're just simply not true. Alternatively, the reality about older adulthood, both in the United States and globally, is that, compared to young and middle adults, older adults actually report higher levels of life satisfaction. And older adults perform better than younger individuals when it comes to remaining calm in times of stress. Older people are incredibly diverse, and the experience of aging is very heterogeneous. Most older people are socially connected. Most don't actually live alone. Most older people live independently, and in fact, only about 3% of older adults live in nursing homes. There are actually lower rates of depression in older adults than in younger adults. And we become more adaptive the older we get, because we have to. We have to adapt and rely on skills that we've learned in earlier phases of the lifespan to be able to navigate parts of the world that may not be designed with older people in mind. On the next slide, what we'll see is that what ends up happening is that we are bombarded by these myths, and over time we begin to internalize them, and negative self-perceptions of aging can quickly follow suit. We internalize the stereotypes. They become negative self-perceptions of aging, meaning a negative view of growing older that eventually is directed toward myself, as I myself become the one that is growing older. Said differently, we store up negative views of aging during the first half of life when we aren't directly the target, but then as we age, we become the target of negative age bias, and we're unprepared for how much that can really impact our lived experience. And so, what ends up happening is that internalized ageism that we begin to experience more and more, it ends up impacting our health and our well-being and even our longevity. Internalized ageism has been shown to coincide with greater disease burden, lower life satisfaction, greater loneliness, even above and beyond other forms of discrimination. And the effects of these negative self-perceptions of aging grow over time, resulting in increased functional impairment, increased experiences of depression, anxiety, and suicidal ideation, even increased mortality risk. And on the other hand, the good news in all of this is that perceptions of aging can also be quite positive. We can cultivate in ourselves and in our loved ones and in our clients positive perceptions of aging, and these can be quite beneficial. They result in lower prevalence of depression, anxiety, suicidal ideation, as well as things like improved strength, gait, and balance, and greater likelihood of recovery after onset of disability. Having that positive view of aging can really help us, and it creates sort of a self-reinforcing prophecy about the value of aging and how it's something not to be feared, but to be embraced. On the next slide, what we'll see is that when you boil down these myths and the way that those myths become stereotypes, and those stereotypes lead to a negative self-perception of aging, all of this has a very real, very acute impact on even things like life expectancy. So you see that number 7.5. Dr. Becca Levy, who is a researcher at Yale University, has conducted extensive research on age perception and how it impacts health and longevity. And Levy and her colleagues have found that individuals with positive self-perceptions of aging outlived those with negative self-perceptions of aging by about 7.5 years, even after controlling for age, gender, socioeconomic status, loneliness, and functional health. And Levy emphasizes that 7.5 years is a really big deal. Compare that to some other key health behaviors that we might think about in terms of longevity. So maintaining healthy blood pressure and low cholesterol, well, that's associated with about 4 years of increased life expectancy. What about not smoking and exercising regularly? Well, those are associated with about 1 to 3 years of increase to the lifespan. So 7.5 years based on this sort of deep-rooted views on aging is really significant. And if you're a bit incredulous about this, as I was the first time I was exposed to this research, consider some of the key mediators that Levy's team found. They argue that it's the will to live and engagement in health promoting behaviors that really becomes a way of explaining the 7.5 year difference. So in other words, when we deeply internalize ageism and then grow older in a society that reinforces age bias, we become susceptible to the belief that we no longer matter. And according to Levy's work, that belief can be deadly for older people. If you're interested, after this webinar, check out the Reframing Aging Institute and their work on the impact of the language we use around aging and how critical this is to engaging older adults and ourselves as people who are aging. And I invite you throughout the rest of this webinar and throughout the rest of your week, pay attention to the age biases that may pop into your head somewhat subconsciously, and just take note of those and keep in mind that we are steeped in this sort of anti-aging milieu, and some of those thoughts and sort of knee-jerk assumptions that we have about aging, they're not things that we consciously put there, but they're part of growing up and growing old in a society like this. The good news, again, is that we have an opportunity to change this, and that change can really pay dividends, both for ourselves and our loved ones, but also for our clients.
Thank you so much, Matt. And I will just echo that opportunity to look for aging, look for anti-aging or ageist ideas. Every single one of us is ageist. We are. We live in an ageist society. Our entire world is ageist. If you go to the greeting card aisle, you will see ageism. If you go to the cosmetics aisle and the number of anti-aging products, if you go to the National Institute of Health and there are anti-aging research drives, we are an ageist society. And we have an opportunity to do something about it right now, right here today. And many of you did ask in the Q&A about additional opportunities to learn about. The National Center for Reframing Aging, the link is in the chat, has fantastic resources for the kinds of pictures that you use in your marketing, for the kind of language that you use when you talk about your clients, for the kind of language that you use in your everyday life. So please do check it out. So on that bedrock of thinking about being anti-ageist, we are going to dive into talking about a handful of process issues. So Bob Knight wrote this book several years ago. It's gone now through its 3rd edition. And we don't have a whole lot of time today, but I'm going to do an overview of the content that I have been teaching to my psychology and social work fellows over 12 weeks. And we're going to do that in the next 20 minutes. So hold on tight. Here goes this opportunity. So as we think about the social context of aging, you just heard from Matt about just how pervasive ageism is in our culture and around the world, the dangers of internalized ageism. And I will say that as that starts at age 5 or 6, as people start to recognize what age is, that can compound over time. And I want to highlight in particular for therapists, the link between internalized ageism and suicidal ideation. So if you ask what your older adult clients think about aging, and I would encourage you to do that, and if you hear primarily negativity, you need to ask about suicidal ideation. And Tracy Gendron has done some amazing research in this space and will continue to do some of that work, as is Kim Van Orden at the University of Rochester. And so as we think about that, ageism might encourage us to believe some fallacies about aging. But the truth is that most older adults have really strong social relationships, albeit smaller networks than in earlier life. Some of those changes are due to attrition. Some are choosing who's worth it to spend time with, right? As we get older, time's limited. I'm only going to spend time with people who I really enjoy. That said, social isolation and loneliness also impact about a third of older adults. So a full discussion of social isolation being the situation of being alone, and loneliness being the negative emotional experience that some have when alone, is a little bit beyond where we're getting today. But I will say that both are associated with significant health risks. You might have seen the Surgeon General's report citing research that loneliness is as dangerous as smoking 15 cigarettes a day. Julia Lundstad, who did much of that research, has also found that social isolation is dangerous and associated with increased disease risk and premature death. So even if you're not particularly dismayed about being socially isolated, you are still at risk. And so we need to pay attention to that in older adults. And even when older adults are living in residential settings. So you might think, well, gosh, there are a lot of folks around. How could you possibly be lonely? Well, loneliness can occur in residential settings as well, particularly when the older adult isn't able to independently leave their room. Saw that a lot in COVID, right? That said, there are some older adults who really flourish in residential settings. My grandmother, when she moved into an assisted living facility, set up daily happy hours where she would play the piano and sing along with all of her fellow residents, and she thrived. She was nervous about going in, but it worked out really well for my very social grandmother. And so she knew everything about what everybody was doing in their lives. And if you've ever worked in a nursing home or visited a nursing home regularly, you will know that the grapevines are alive and kicking everywhere. So I say that to say that everyone will know if a psychologist or counselor comes to visit Mrs. Jones in room 222, and Mrs. Jones' daughter may also want to know what's happening in psychotherapy. And as you think about that setting and social context, if Mrs. Jones has decisional capacity and decides that her daughter does not have access to such information, you'll need to be clear about that. So just a couple of pieces about this social context. Again, just highlighting that the vast majority of people over the age of 65 have very strong social relationships. And yet, when they are internalizing ageism, may underestimate what they can do independently. And part of our job as therapists, particularly when individuals are experiencing depression, anxiety, any other mental health issues, is to be able to poke a little bit at that ageism. And there are actually clients for whom I will have conversations about just how ageist the view is. When I talk about normal adult development, I talk about a client who was referred to me by physical medicine rehab doc, somebody who had decided after being a very physically active guy and a very physically active job that when he retired, he was just going to sit down and put his feet up and do nothing. He had no structure to his days after he retired. He didn't have any activities. He didn't have any social activity. Pretty much everything that made him thrive as an adult, he stopped doing. So he gained weight, he got depressed, he got sick, and he couldn't walk very well, which is what took him to PM&R in the first place. And so, he would sit on the couch and fall asleep during the day, doing lots of napping. And so with that napping, he then wouldn't sleep very well at night. And all of this, he and his family thought were normal aging. That's just what happens when you get old. You get fat, you get sad. Let me tell you, that is not normal aging by any stretch of anyone's imagination. It was his behavioral choices. And so when people misconstrue what aging is supposed to look like, right, and that's a factor of ageism, they are unhealthy. And so part of our job is to help people recognize, gosh, you know what? It turns out that when you were social and when you were physically active, and when you were actually interacting with your environment, you were a heck of a lot happier. Let's see what we can get back to in that space. So in addition to social context, one of the things we can think about are cohort effects. So, excuse me. one of the things we have to be careful about is the idea that clients might share your worldview. One of the questions that came up yesterday in our conversation is, how do you deal with older adults who think that their therapist, who is way too young to even begin to understand what's going on, could even possibly help them? Well, one of the challenges for that young therapist, or for any of us, is that if I view the world through my own particular lens and I assume that the person sitting in front of me looks at the world through that same lens, I am not going to be successful as a therapist. And this is particularly true for adults who have lived through multiple wars, who were alive when there was no such thing as a computer, who were alive when we didn't have these little devices that seem to be attached to everyone's hips and hands these days. And so their concept of the world may be very different. But this is also the coolest thing about working with older adults. And, the whole big part of the reason why I went into working with older adults in the first place is that, my gosh, in my second year of graduate school, which was my first opportunity, I found out that I was learning way more from my older adult clients than they were getting from me. And it was the coolest thing. And even as I was engaging in that activity, I found myself using my own cohort language. One of the things I've picked up from my 20-something project coordinator is cool, cool. She says, cool, cool, a lot. And one of my clients is saying, what are you saying? Are you cooing at me? I don't understand what you're saying to me. And I've had to pay attention to my own language. And we need to be really careful, even about language around mental health. Right. So one of the things that research has shown, and certainly in my own clinical practice, that older men will not respond likely to the word depression. And older women are unlikely to respond to the word anger because it has been culturally instilled that women aren't supposed to get angry. I might get frustrated, I might get irritated, but I don't get angry. And so attending to that cohort-based language, and again, the person sitting in front of you may not have those issues, but you need to pay attention to what that language might be, and also what the language around mental health might look like, particularly in the context of stigma. So whether we're talking about the stigma of mental health for a cohort that grew up at a time where we don't air dirty laundry in public, and that includes with a therapist, there is a powerful stigma. Now, the folks who are at the younger age, so 65 to 75, may have benefited, and say what you will about Oprah Winfrey, but Oprah Winfrey put mental health on the dinner table conversation list. And whatever else we might think about her, that is one powerful thing that she did and made it part of a normal part of conversation. But folks who are over 75 may still not be comfortable about that and may have social stigma about what's acceptable even in social interactions. So for example, if you're talking to an older woman who never married and never had children, or a man who retired early, or expectations for happiness in a marriage. So, and I say this in particular for those marriage and family therapists who may be doing couples counseling, looking at concepts of what marriage is in a particular cohort and in a particular family, recognizing that that might not be the general culture of the younger cohort. So attending to what stigma looks like and really investing in understanding that historical culture. And part of that historical culture is really understanding a little bit about history, right? So understanding what it was like to be a civilian in a war time, or going through the Great Depression, going through perhaps an older adult who may have immigrated to the US in the 1920s, very different from the experience of what's happening around our borders at this point in time. Folks who went through Prohibition. And so if you're not aware of those things, ask questions. Give your client the opportunity to teach you, but you also have an opportunity to do some of that research yourself. Go watch some movies. One of my first supervisors when I worked in a nursing home, God love this man. He was a pediatric psychologist who was looking to pick up some extra dollars, not a geriatric specialist. When I asked him for extra reading, he said, "Oh, you should go read The Greatest Generation. Great book. Tom Brokaw. You should go read that. That's your extra reading." Oh, okay. Now, it turns out it was not a terrible recommendation to understand the culture of the baby boom generation, but and this is something that you would benefit from. Talk to your parents, talk to your grandparents, and understand some of that culture. And some of that culture and some of that historical context is part of what drives perceptions about roles, social roles, that drives perceptions even of the healthcare community. So the older of adults tend to defer to doctors, right? And the 65 to 70 folks much more likely to feel empowered enough to ask questions and challenge and push back. And so getting a sense of whether your client is just yes ma'aming you, or whether that actually means that they're on the same page. So understanding where that culture can come from. And so as you're doing this work, it's also important to understand what's happening cognitively for your older adult client. And so wanting to highlight some of these positive pieces that, again, one of the really cool things about working with older adults, in contrast to working with children, is that when they are facing a challenge or a conflict, they have resources, they have experiences. And so you always have the opportunity to say, well, gosh, when you've been in conflict before, what have you tried? What's worked? What hasn't worked? And they have decades of experience to reflect on about what's worked and what hasn't worked. So that long history of relationships can actually be an incredible amount of expertise that they may just need your guidance in how to tap into. And so being able to ask those questions and being aware that your client might know a heck of a lot more than you do about a lot of things. So again, that being open to learning from your client, and one of the most exciting parts to me about working with older adults. And in that context, again, ageism would tell us that all kinds of things about what is normal aging. There is a small amount of cognitive slowing that is part of normal aging from baseline. So what that means is that if somebody is highly educated, highly intellectually engaged in the environment, highly social, that cognitive slowing likely has absolutely no impact whatsoever on function. And this is why, even on cognitive screening instruments, why people who are highly educated tend to top out on those instruments, and that's not a great it's not a great indicator. In contrast, folks who are who have very low levels of education, the screening measures tend to underestimate their level of function. I will say that in terms of the context of psychotherapy, older adults do tend to have a smaller capacity of working memory. So any of us has a 7 plus or minus 2 things we can keep in our heads, right? This is why phone numbers are 7 digits. And we chunk them, which means we can have the area code and then 3 and then 4. This is part of that package. As we age, those buckets get a little bit smaller, right? And so we may be less likely to hold a lot in our minds at one time. And so as we're having conversations, sometimes the conversations might need to slow down just a little bit, right? I don't talk nearly this fast when I'm talking to older adults, but it's an interesting titration between not wanting to slow down and be condescending, but also not wanting to talk so fast that nobody can understand what you're saying and there are way too many words going on right now. So attending to the pace of conversation, attending to the person sitting in front of you, and much like we might with other clients, doing a fair amount of, I've been talking for a while. Tell me what you've been hearing. So you're checking understanding, you're checking that they're following. Therapy tends to work a little more slowly in working with older adults, although again, lots of individual variability here. And whereas an 8-session standard cognitive behavioral therapy manualized treatment, which I really struggle with manualized treatments myself, but that would probably need to be stretched into 16 sessions so that there's time for practice, there's time for integration. Part of that has nothing to do with cognitive functioning. Part of it has to do with I've been doing the same thing for in the same way for 75 years, and it's probably going to take me a little bit more than 6 weeks to change this habit, right? And so we want to be careful of overgeneralizing some of these issues. Whoops, moving a little too quickly here. And so in that space, wanting to comment on cognition, a lot of neuropsychologists who are less invested in the concepts of fluid versus crystallized intelligence, but I bring it up here to crystallized intelligence is the content of what we know, right? That doesn't change very much as we age, kind of the what we know. The fluid parts in terms of speed of processing and reasoning do decline a little bit. And so this is part of the slowing piece, right? And it's also potentially using more concrete examples and helping your patient walk through problem solving steps, and know your client, try things out. Right. And so, for example, I worked with a retired university professor who was utterly brilliant, but emotionally stunted. And I ended up asking one of my pediatric colleagues for an emotion wheel. And we used the emotion wheel regularly to help her name her emotions because she was so alexithymic that she couldn't even come up with anything beyond upset. So, also in that process of therapy, I do a lot of writing down. So as we talk about what the key issues are that we talked about in therapy today, I will write it down, give it to the client to take home. I request that all of my clients have a therapy journal so that they're also writing down what they're hearing and what's important. Asking one question at a time. Young people, as are notorious, my goodness, are notorious for asking, so how are you thinking about this? Are you thinking about it in this way? Or have you really even thought about it in this way? Or one other thing I was thinking about, right? There's 5 questions right there. Which one do you want me to answer? I'm having a hard time following. So attending to that, attending to jargon, we were talking about language before. And so I want to, as I'm noticing the time here and wanting to move forward into our last chunk here about emotional changes in later life. So we talked yesterday about the idea that older adults tend to have mental health and substance use issues less frequently than younger adults, pretty much across the board. Part of that is that older adults tend to experience less intensity in emotional reactions and tend to be somewhat less expressive. Now, I want to say again, from their baseline. So I am a very emotionally expressive person, in case you hadn't noticed today. And as such, I will very likely, as was my very social grandmother, be more expressive than the average person. But as I age, I may become less expressive than my baseline. And there are particularly in older men who, again, have been socialized that being very emotional is not acceptable, with the exception of anger, perhaps. Attending to what that emotional experience might look like. And you may need to check in with your clients about what you're seeing on their face or in their body language that may be different or similar to what they're actually feeling. And 2, with many years of experience under one's belt, there may be a more complex mix of emotions. And for some, they might not have all the words to describe those emotions. So with that, just a taste of some of the critical issues that may come up in the course of psychotherapy. And again, I mentioned these books yesterday, fantastic books that I would strongly encourage. A Theoretical Orientation, Assessment and Treatment of Older Adults by Greg Hinrichsen. Those of you who might be cognitive behavioral in your orientation, Stephen Thompson and Gallagher Thompson's Treating Later Life Depression is a fantastic resource, really great resources in that book. I'm going to pause here for just a minute and hand over to Matt to make a few additional comments.
Yeah, I just want to thank everyone for making the time to be here. We know aging affects all of us, and this is really a critical opportunity to re-examine assumptions about aging, to engage older people in the mental health services we provide. So with the timing of Medicare reimbursement opening up the floodgates for licensed counselors and therapists, this is just a really important time. And so thank you for making yourselves available to that. Keep in mind that due to a number of factors, historically, older adults have been overlooked by the mental health care space. And so it's critically important to consider how to make your services available and accessible to older people. That's a big part of making healthcare more anti-ageist, is to allow for our services to allow older people to participate and to experience the breadth of what it means to age well, including from a mental health standpoint. That might mean that you have to proactively look for ways to make your services more accessible by linking up with primary care providers, linking up with aging services professionals, not being afraid to think more creatively about how to get the word out about the work that you do, and not just waiting for older people to find you, but thinking about how to position your services so that they can be easily found and accessed by others. So as you're thinking about strategies for that, make some phone calls to your local area agency on aging, do a late life depression seminar for your local senior center, reach out to continuing care retirement communities in your area, look for ways that you can take your expertise to older people in the spirit of helping them age well and really learn how to defy some of these ageist assumptions that that all of us are grappling with. So thank you again.
Thank you, Matt. And I will just make a couple of really quick plugs. As I mentioned yesterday, a fantastic special issue on the foundational knowledge competencies in geropsychology. Some really great information here. The link is in the chat. And we have a workshop coming up on implementing the 4Ms behavioral health, applying the 4Ms of an age-friendly health system in mental health and substance use services. This is a fantastic place to get started if you want to modify your practice. It's a 3-hour workshop followed by 1 hour a month through September. Would love to have you come and join us for that program. And also, if you want to dive into learning a lot more, we have a 16-hour mental health foundational competencies in older adult mental health online certificate program that is available to you free of charge if you want to take it. Continuing education credits are only $175 for the whole package. And for you today, 25% off for all of you, which makes for incredibly inexpensive continuing education credits. Would love to have you come over and join us for that program. And please do check it out. All these links will be sent to you in an email as well after today's event if you missed any of the links. If there is additional information, I know in the Q&A there were lots of questions about, do you have resources for this or more information on that? Please come check out catchon.org and e4center.org. We've got a lot of resources, a lot of educational resources. Please don't hesitate to reach out to us as well at either of these email addresses for more information. And I know, Julie, we've run way too long here, but I'll turn back over to you for Q&A.
Not a problem at all. I want to thank you, Dr. Emery Tabricio and Dr. Fullen, for sharing your time, your knowledge, your experience, your stories with us again today. We've heard, a really great deal of information about working with older adults. You provided information, but you've also challenged us to take a hard look at our own biases or biases, which I think is a good thing for everybody to do here that's on the webinar. We really appreciate your partnership with mental health counselors and with marriage and family therapists who are now becoming an integral part of providing services to Medicare beneficiaries. So as you said, we're now going to move into the Q&A portion. We don't have very long for that, but we're going to answer a few questions as much as we can get to before we have to end today. So let me just take a few of them. One person wrote in wanting to know if you could speak about prolonged grief among older adults, if that's something you could address.
Sure, we talked a little bit about it yesterday in very briefly, but the idea that prolonged grief disorder is distinct from normal grief in that it incorporates an intense yearning or longing for the deceased, along with a number of behavioral components, including thinking that you're seeing the individual around the corner, being hypervigilant, so some of the more PTSD and attachment related kinds of symptoms. And prolonged grief grief disorder is no more prevalent in older adults than it is in younger adults. And that line for prolonged grief disorder can sometimes be a little fuzzy. If you think about somebody who's been married for 50 years and then loses their partner, it would not be unexpected for that individual to continue to grieve for the rest of their lives. That said, we would expect that within a few months, that same older adult who is continuing to grieve would reintegrate with their normal lives, even if they feel somewhat of a shell of themselves without their partner. So that line of what is actually prolonged grief disorder gets a little fuzzier when you're talking about that kind of a loss. That said, if somebody is experiencing a lot of distress and not able to engage in their regular functional tasks, I would say absolutely psychotherapy is very appropriate, and processing that loss. And a big piece of that for older adults would be to re-engage with who they are as an individual, and who they are even without their spouse, and also who they are with their spouse. If you're interested in learning more, I actually, on the E4 website, if you go into our webinar archive, I gave a lecture on grief and a practical approach to grief that might be very helpful, and happy to share that with you on the E4 website.
Wonderful. Thank you for that information. Another person had written in wondering if you could talk a little bit about resources for addressing trauma bonding with older adults.
Not sure what's meant by trauma bonding. We do also have some lectures recorded on the E4 website about trauma-informed care and about addressing trauma in older adults. The Veterans Health Association also has lots of fantastic resources about trauma among older adults that can be incredibly helpful. And Matt, was there anything else on trauma that you would want to address here as well?
Just that it tends to be, older adults tend to be overlooked when it comes to trauma care. So many students who are interested in trauma and learning how to provide better trauma treatment, and rarely are they thinking about older populations in that context. So it's a really important question, and I appreciate that. There are resources like what Erin has with an E4. And it's important to note that, when you're working with older adult clients, even if trauma isn't the most overt diagnosis, there's often cases where once you start to peel back the layers a little bit, there is trauma that may have never had an opportunity to be addressed underlying some of those things. So great question.
Thank you. Another person has written in asking if either one of you could speak to the cultural differences in language and the perception of older adults. I know you spoke a little bit about that, but could you elaborate on that?
I can take a stab. There are certainly cultural nuances when it comes to the sort of core beliefs about aging and about where older adults fit within the family, within the community. And so, I hope that what we shared today can really be a starting point for more discourse around how we think about aging and ageism, but it absolutely has to be, conversed about within the context of intersectionality and all of the other identities that are at play. It is possible that some terminology that works for some communities may not work for other communities, and we have to be sensitive to that. But it's really important to be able to tune in and to think about how those ageism kind of assumptions intersect with other, race, ethnicity, sexual orientation, a lot of those other pieces.
I would echo that and just say too that, the research that I talked about in terms of elderly versus older adults was done in English in the United States. And so what words are appropriate in other languages, in other cultures might vary wildly, and we don't know about that. And so, I think there was one of the questions also in the Q&A said something about, well, shouldn't you just ask the person in front of you what they prefer to be called? And that is certainly an approach, but one caution about that is that because we all live in an ageist world, the person sitting in front of you may have internalized ageism and believe that they should be referred to as someone who is frail or elderly, right? And so we have to take some bit of caution there that we all live in this ageist society, and so what we identify with might also be reflective of bias. So just tread a little carefully and perhaps even think about, what does that word mean to you and how does it feel, and be able to talk about the meanings of those words, and what that means for that individual's identity.
Very good points. Unfortunately, we don't have any more time for questions. I wish we did. We do have a few more that have come in, and we're going to attempt just to collect those and maybe share them with Aaron and Matt, and we might be able to just, get answers to you all later. I'm sorry we don't have any more time for those today. We do have to end now. The Medicare Mental Health Workforce Coalition and NBCC would like to thank our speakers, Dr. Emery Tabricio and Dr. Fullen, for sharing your knowledge, and to all the participants for attending today's and yesterday's webinars. The link to the session evaluation is posted in the chat, and we're also going to be emailing that to you following the meeting. To receive continuing education credit, you must complete the evaluation, including the attendance attestation, by April 4 at 5 p.m. Eastern Time. And as a reminder, the continuing education survey will allow you to complete the evaluation for one or both of the webinar sessions. Certificates will be emailed by April 11. We will only be providing credit for the live attendance of this webinar. We hope you found this session informative, and we look forward to seeing all of you again soon as we continue our Medicare webinar series on April 18th. The focus of the April webinar will be navigating the Medicare Advantage plans. We will let you know when registration begins. So thank you all, and have a wonderful rest of your day.